Next speaker and presentation is Raul Mill from Estonian e-health foundation. So we have nicely mixed the academia and the practitioners. And Raul will talk about how their health make life better for live users.
Exactly. Thank you. Good afternoon.
Life's longer for live users.
Good afternoon, professors, teachers, students, ladies and gentlemen. As Peter said, I am Raul Mill and I'm coming from eHealth Foundation. And I would discuss about the usability of eHealth services on the example of Estonian eHealth system. Estonian eHealth system is one of the best maybe in the world. Why? We have three good things in Estonia. We have good internet connection which covers all our state. We have X-Road, security environment for the documents exchange, electronic documents. And we have opt-out system. It means that by default all medical records are open for physicians and patients can close documents if they want. Many countries have opt-in system. That means every time if you need see medical records, you have to ask from patient, is it allowed? So if I can get my presentation. I could show you also some pictures. Many countries develop today their e-health systems and they hope to save quite a lot of money. For example, in Scotland, approximately £60,000 have saved every month thanks for telehealth services. Different countries have quite good systems between hospitals and health service providers, but they have local systems. Estonia has one common system. Different countries are solving such a problem today, how to connect these regional systems. For example, our northern neighbors, Finland, has very well developed systems based on light cables between regional hospitals. Today they intend to start to use and develop such a common system which is based on Estonian X-Road standards. Do you know what this is Estonia? But I would start with one simple example, and not at all from IT. Why? Because medicine itself is not IT. It contains a lot of IT, but it is not IT. When we speak about usability, we have to speak about user experience. And we can divide these components into four parts. Value. Such a simple boat, is it useful? I guess it is if I want to go fishing. Is it easy to use? I guess yes, no problem. Adaptability. Is it easy to start with using? Yes, if I have some pads, I can start using it at once. Desirability. Is it fun and engaging? If I'm fishing every day, I guess it's not fun anymore. If I intend to spend a romantic evening with a beautiful lady and enjoy sunset, I guess yes it is. So these factors depends a lot of the purpose of the system. E-health, I put here only 4 important participants. 2 of them, physicians and patients, are users. 2 others are financing and developing e-health system. Here is one common point, treatment quality, what is important for all these participants. These 4 usability and user experience aspects depends quite a lot on these purposes. Do we want cheap system? Do we want fast system, comfort system, and so on? So it's quite complicated to find this compromise between different participants to develop e-health systems. The key question for all states is today how to update these services. Creating software or whatever product first is quite important to develop and design this product valuable, adaptability and desirability. 3 important points for people start to using this product. Usability is not so important in the beginning. For business, it's very important that people buy and start to use the product. Afterwards, when people already use this product, they have some experience, usability is much more important, and then the design of this product will turn into more important. Wages of these components depends on the purpose. Enterprise software, mostly e-health services are also enterprise software. The value of this product is very important. It is for make better work. Also, usability is very important. Adaptability is less important because mostly some IT services, background services are cover this part. And desirability is also not so important because it's a tool, it's not for fun. Computer game, on the other way around, value is not important, it's entertainment. Desirability and adaptability are very important. It's very important that I can take the software and start to use without reading any manuals and so on. It has to be logical and fun. And if it is, I can tolerate poor usability even, if I enjoy this solution. Social networks. The value and usability are somehow important. I get some information from this network, but more important are desirability and adaptability. I want to start use it at once, and I want somehow that it is fun. E-commerce, eBay, good example. All these 4 factors are equally important. I want to get some value. I want to buy or sell something. I want to find out fast, interesting part of this site, of this environment. I want somehow that it is fun or that the site, that I like this site, let's say, and I want to start to use it also at once. Estonian e-health system started to create in 2000. Over 100 persons was involved in the process. Physicians, manager of big hospitals, patients. There were 2 expectations: fast and simple system. there was necessity to exchange medical information between different health service providers, between hospitals and family doctors. In 2004, first project started, and in the last end of 2008, system went to the production. This is the base of Estonian e-state and also e-health system. This is the X-road and secure documents environment. ID card and mobile ID. Mobile ID has more better usability than ID card, I guess. Why? Because you use your mobile ID every day. You have it with ID card. You have to take with. You have to have also ID card reader. This is architecture of e-health system. Different databases, State Agency of Medicines, Healthcare Board, Population Register and Business Register are used in this system. Hospital, family doctors and pharmacists registries are connected over X-road. Also school nurses and medical emergency services. All these databases are connected over X-road with nationwide health information system and with prescription center. Prescription center is managed by Health Insurance Foundation. Other services are managed by eHealth Foundation. And why these databases and registers have to be connected? For example, a physician can access to the central system only in case he has license. It is controlled via Healthcare Board. Also, he has to have license for providing services. It is controlled via Business Register and so on. The structure is conditionally built up as a three-level model. The base level, the central database, contains legal framework and standards. Standards are quite important aspect from the usability. We need to speak the same language, we need to understand same things, and we want to get things as detailed as it possible. As much we have free text, the less we can detail it. The upper level is process level. We need good process description for creating good system. And middle level, the middle one, is data exchange level, also user interfaces and different data transmission standards. Estonian e-health system is quite interesting because it has built up separately. We have central database and central services which are developed and financed by government. And we have 8 main softwares which are developed and financed by health service providers. So if we are creating today one new e-health service, there is necessity to develop these all 8 softwares simultaneously for using this central service. Security and usability. The security of the system is very important. I guess all people believe it. But it's not very user-friendly sometimes. Many hospital information systems, their own information systems, are accessible via simple PIN code. Central system need login via ID card or via mobile ID. Physicians use averagely 3 information systems: their own, the central system, and system for viewing X-ray pictures. So it's also system is valuable. It is not desirable, I guess, but it shouldn't be. It can be somehow adaptive because users use their own system anyway. But today we are creating more and more usability system. Estonia keeps the first position among 30 countries today in offer use indicator and e-health availability. This is research made by OECD in 2012. It's not yet published, but it is presented in this year already. And one interesting thing more, we are a small country and we have spent money for the nationwide system much less than bigger countries. They have bigger possibilities. But we have, I guess, not worst system. We have at least same good system. One illustrative theme about different partners in e-health system. E-health Foundation have founded by 7 founders. There are 3 bigger Estonian hospitals, also hospital association, also Union of Medical Emergency and Society of Family Doctors. It also illustrates how complicated the system actually is. Where we are today, e-prescription covers 94% of issued prescriptions. Over 90% of hospital discharge letters are digital, and over 97% of stationary cases are sent to the central system. First year of e-health system, the usage was very, very low. It was a circulus vitiosus, the value of the system. If system doesn't contain data, it's not very valuable. If it's not very valuable, it's not used. The breakpoint, actually there are 2 breakpoints in the middle of 2010 and middle of 2011. The usage of systems started to increase quite rapidly. These waves are occasions. Today we are developing many new services. We are developing e-ambulance system, e-laboratory, digital registration, different registers, e-certificate. Today you need to go to your family doctor, have some medical controls, get paper certificate, and give it for getting driving license or gun license or whatever. In next year you can avoid this process if you have lately have had medical examination. You can get a certificate via patient portal and forward it electronically to any institution if you want. But these all services have different design, different usability. This is a prescription. Okay, these are e-health services which are completed, which are under the development, which are under the planning, and which have also different supporting infrastructure, external and sub-services which are invisible for end users, but are necessary for working these end user services. I wasn't here in the morning. I heard that Peter criticized somehow this patient portal. Yes, the old version of patient portal wasn't very user-friendly. Today we are collecting feedback about this new patient portal, which started to work from July this year. What you can use here? You can see your medical records. Yes, it's important that your doctor sends your medical records to the system. Otherwise, you can't see these records. But you have asked your doctor. I just very soon show you statistics about family doctors, how they send documents to the central system. Also, you can see your analysis, vaccinatings, prescriptions. You can allow or decline blood transfer, organ transplantation, and usage of your body for scientific purposes after your death. Also, you can give access for different people manage your medical data. And you can, of course, close your data, and you can monitor who about physicians have looked your data. Yes, this is statistics of patient portal. The usage haven't been very high, but it started to increase beginning of this year. Standards are quite important. I already mentioned it. So, technical standards and data standards for creating good system. And the process of working out standards is also quite complicated because we have a lot of participants who has very often their own standards, and some of them have to start using new standards. It's not very easy if you have some old processes which you're using every day. These are main principles of e-health system, security principles. I would stop more longer of the second aspect, digital signing. Since this year, all family doctors had to sign all electronic documents one by one. You can imagine if you spend, let's say, 20 seconds for one document, you need about an hour in a day for assigning all documents you are sending to the central system. It's quite a big time wasting. Since this year, family doctors has digital stamp. It means that they can send all documents together. Just push a button and all documents are sent. And thanks for this solution, sending of medical records to the central system increased up to 3.5 times. So I hope very soon you all have medical records in the central system. Last year, in the beginning of 2012, 42% of family doctors didn't send documents to the central system. Today, the number has decreased 8.4%. It's a very good result. Some of doctors don't like computers. It's a problem of age, I guess, maybe. Who knows? About the future, what we need for creating systems with high usability. As I mentioned, today physicians have the 3 times authentication. On the central level, single sign-on solution have realized. Now we have to realize it on different softwares. We need to collect information automatically from different systems. Today, physicians make queries to the different systems manually. They open document in their own system, they make queries to the central system for knowing does this system has information about the patient, and they need extra pictures and descriptions about these pictures. We need to develop a system for making automatic queries that the physician enters patient personal code or opening document in his own system, and automatic queries will be sent to the different systems, and information will be collected to the desktop of your doctor. It is proved that entering data to computer takes more time than writing by hand the information. Voice recognition solution is very common in the world. It's not something new, but it's not realized in Estonia. We have actually such a prototype solution near Technical University. We are developing this system. Today we have also medical specific prototype for text input assistant, which is working like Google. The most frequently used medical phrases will be offered to the doctor. It's possible to choose it on keyboard or by mouse. And what is most important, all these text phrases are actually coded. So it means that the doctor can enter free text choosing these phrases, but the text is all coded. It's not actually free text, it is standardized. User interface standards, quite important aspect of usability. We have 8 main softwares. Physicians working simultaneously in different hospitals. They use different softwares, and they have to find out different locations of necessary buttons and fields and so on. We are creating these standards. Apps for medical specialties. Every specialty needs some different aspects of the software. We need adaptive systems. If we have, let's say, 5 cardiologists in hospital, it's pointless to develop such a special software for 5 cardiologists who need to manage, say, EKG diagrams. If we can create these apps for all cardiologists in Estonia, let's say 50 or 100 cardiologists, maybe more, it can be economically reasonable to create. It is possible only if we have web-based systems. Today, many systems are standalone. It is location independent. Say your doctors need to access to the system from hospital, also maybe from different hospital, maybe at home. So I guess the time of standalone systems will be over very soon. Graphical solutions. You know that one picture can give you much more information than many lines of text. These graphical solutions in healthcare are very well developed. For example, X-ray softwares. There are three-dimensional solutions and very well solutions. These are not very widely used in a general health records. If you are a patient, you are visiting your family doctor today, and yes, you can look your medical record via patient portal at home, half in Latin, half in Estonian. Maybe you understand something, maybe not. It depends how detailed your doctor explained your treatment process and your disease. If you can look some anatomical themes about your disease, get explanations about complications, I believe you understand your treatment process much better. You can show this also to your friends if you want afterwards, and also say I understand this process. The base of these things will be integration, so-called integration platform. We need to create this platform based on different standards. This platform for connecting different systems, different hardware, and also connecting different devices which are not healthcare system devices for providing additional value. For example, you as a patient want to connect your sport monitoring data with your treatment data. Today, you can do it only manually, typing your medical record data to this device which you bought and which is monitoring your sport data. In the future, it's possible to connect all this data if you want. Of course, it's only if patient want it. So, I guess my time is over. Thank you very much.
Are there any questions from the audience side? There is a microphone here, a microphone there. Please, first.
Do I understand correctly that all the medical record data is available to the patient, visible, including all the analysis results and also perhaps the medical imaging?
Yes, medical imaging are not accessible today because of the big size. But all medical records are accessible for patients. Only your doctor have to send these records to the central system.
Okay. The reason why I asked about the medical images is because, for instance, if I'm seeing my physiotherapist, he will want to have a look at my latest spinal X-ray, perhaps. So it would be rather handy.
Okay. All doctors, yes, can look these X-ray pictures. All X-ray pictures are accessible for physicians.
Yeah, but I meant physiotherapists. They are probably not registered healthcare providers.
If these therapists have a license for providing health services, then yes. If not, then no.
One more thing, I haven't had a look at the latest version. My latest experience was quite some time ago, and at that time, a simple blood test that measured 10 parameters filled about 5 screens, because the area used to display those analyses was very small, and each analysis result was entered as a separate record. So there was very difficult to get an overview of the full situation.
Yes, you mean that why you can't see all analyses together?
Indeed.
Yes, it is a topic of e-laboratory. Today, all analyses are collected as a part of the treatment summary as epicrisis, and they are collected on the shape of text. In 2015, the e-laboratory service will be completed, and all laboratory analyses will be connected to the central system as numerical values. And it will be possible to collect, see all analyses together, and make queries also via different analyses or criteria.
Thank you for the presentation. And I have one question: is how do you measure the user feedback, or how do you gather this feedback from doctors or patients? Do you do that?
We have made some feedback researches, some these big questionnaires about usability. We didn't measure this physically since today, but we intend to do it together with physicians in next years. Since last year, we have a so-called medical advisory board near our institution, which helps to understand better physicians' needs and measure this.
Yeah, but one side is the doctor side, but from the user perspective, I mean, like from the patient's perspective, do you work on that also, so it could be more convenient for the users?
Yes, of course. The new patient portal have already worked out with by the rules of interaction design. We have prototyped this solution. There are many aspects for younger people, but yes, scale of age is very large of users, so it is a complicated factor.
Okay, there is no very active question part, so I can switch over to the next one. So thank you, and we have a present for each speaker.